And good morning to one and all. Today we are going to study on the topic classification of malnutrition. Contents include what is malnutrition, uses of classifying malnutrition, types and terminology of classification, and this classification, its drawbacks, and its modification. First, determine what is occlusion. It's defined as the relationship of maxillary and mandibular teeth when the jaws have close inside stimulation without strain of the musculature or displacement of condyle in their face. A malocclusion would be departure from this normal relation. That is, its condition in which there is a departure from the normal relation of C to the other C to the same house or to the people in the existing house. What is the use of classification? In general terms, it is useful in diagnosis and treatment planning, and also after treatment, we can assess how the treatment has put forth the treatment patient. Useful in locating the problems with classification, helps in communicating the problem. Comparison of unit malnutrition are based usually by linear classification, using epidemiological studies, and for documentation of the problem. Various methods of classification include would be classified based on quantitative or qualitative methods. That is, quantitative is usually quantifying the amount of discrepancy present in the malnutrition. That is in terms of millimeters. An example would be index of orthodontic treatment use, wherein each discrepancy is quantified in millimeters. And qualitative would be the malnutrition can be classified based on certain qualities, like whether that is any mad leadership of molars or incisors. One example would be angle system of classification. And classification also could be done based on inter-arch and inter-arch problems. Inter-arch problems are the malnutrition or discrepancies that are present within an arch, that is either in the maxilla or mandible. Inter-arch would be the malnutrition that is present in relation to both maxilla and mandible together when there is an occlusion. Inter-arch problems would be malnutrition you could see in different planes, that is, it could be sagittal plane, vertical plane, or transverse plane. In inter-arch, in sagittal bronchoceles, labioversion, lymphoversion, mesioversion, discoversion. That's labioversion proclamation, lymphoversion, proclamation. Vertical problems include supraversion, that is supraeruption, and infraversion, and rotation and transposition. Inter-arch problems include in sagittal plane, class 1, 2, 3 malnutrition, transverse, posterior cross and cervical, and midline. Vertical problem, T5 and open. That is deep in depth angle system of classification. This put forth by Edward Hartley Angle in the year 1899. He is also known as the father of modern orthodontics. This classification is mainly based on the angle-posterior relationship of teeth with each other. Angle used mainly two main concepts, that's theory of occlusion and line of occlusion. In theory of occlusion, he used the maxillary first molar as the main landmark, and he stated that maxillary first molar is considered to be a theory of occlusion because he considered the position of maxillary permanent molar to be consistent or relatively stable. And line of occlusion, as you can see in the figure, is the path or is the point along which the occlusion is there between the maxillary and mandibular teeth. And in the upper arch, this line is like a capillary curve that is passing through the central foci of the posterior and along cingulum of the anterior. And in the lower arch, it is seen as a capillary curve passing through the buccal cusp of the posterior and along the incisor edges of the anterior. These are nothing but points where the upper and lower teeth or arch where the upper and lower teeth are protruding when the teeth are in closed position. So this is line of occlusion. So how did we use both of these concepts, that theory of occlusion and line of occlusion, in classification? So in normal occlusion, we said that the theory of occlusion, wherein he stated that in a normal class 1 relation or in normal occlusion, the mesiobuccal of upper first permanent molar should occlude with the buccal teeth of the lower first permanent molar. That is said to be a normal class 1 or a normal relation. And the line of occlusion, as we have seen before, the Saturn curve, it will not be altered. That is, the curve will be a pure curve. There will not be an alteration in Any of the two relations, that is normal occlusion. In class 1 malocclusion, the molar relation would be stable, that the means of the of the upper first terminal molar will occlude with the buccal groove to lower first terminal molar. There will be deviation in line of occlusion, that is, there will be either spacing, crowding, proximation of the teeth. That's the main difference between the normal and the class 1 malocclusion. In class 2, the histomuscle of the upper first terminal molar will occlude with buccal groove of the lower first terminal molar, and there will be derangement in line of occlusion. In class 3, the mesobuccal cut of the upper first terminal molar will occlude in interdentine region between the lower first and terminal molar, and there will be derangement in line of occlusion. This classification, that is, it is classification occlusion according to Mandel, it may be four, that is normal, class 1, class 2, and class 3. Whereas classification of malocclusion is maybe 3, that is class 1, 2, and 3. Now the three of this in detail. And this class 1 malocclusion, so all the malocclusion in each class of malocclusion and we defined it based on the molar relation, canine relation, and line of occlusion. The molar relation, as we've seen before, when mesobuccal cut of the upper will occlude with the buccal groove of the lower in class 1, and canine, the mutual incline of the upper canine or maxillary canine will occlude with the distal incline of the lower canine. And line of occlusion in class 1 malocclusion will be altered. That is, there will be individual tooth irregularities or there will be certain inter-class problems. That is class 1 malocclusion. Another scenario that is seen in class 1 cases are class 1 bimacular occlusion. So this is the condition in which the molar relation will be class 1 and the tooth will also be in proper line of occlusion. That is, it will be generally we could say that the tooth will be slightly in contact and the lack of spacing, unlike the case in this. Mostly it will be slightly contact. It will be slight contact with each other. But the only thing that we see is that upper and lower teeth are friction. You could say that class 1 bimacular occlusion is a condition where both P of occlusion and line of occlusion are not altered most of the case. Upper and lower anterior teeth are proclined. That is, it is also stated as bidental protrusion. That is, only the teeth are proclined. And they exist usually in exoexcellence. So that is another type of class 1 malocclusion. Now, and this class 2 malocclusion. Here, we stated that the molar relation has the distal-buccal cut of upper first terminal molar occlude with the buccal groove of the lower first terminal molar. And canine relation, the distal incline of the upper canine will occlude with the mutual incline of the lower canine. There will also be alteration in the line of occlusion. Now, we have subdivided class 2 malocclusion into maybe two types. That is class 2 division 1 and division 2. In division 1, mainly some of the features include proclined upper incisors, as a result of which there will be increased overhead and deep bite. Because of this increased overhead, the lower lip will be trapped between the upper and lower anterior. As a result of the feature called lip trap is seen in this case, and the upper arch usually is V-shaped, narrow upper arch. And there will be increased chances of tissue finding like hyperactive mentalis because of the lip incompetency. It could also be the hyperactive mentalis activity, a clinical sign that can be checked with Gall's palsy, whereas the patient when they are trying to put the lips close together, or they are trying to close the lips, we could see that putting up the lips, or we could see that in the more thing, the typical feature of Gall's palsy is the same hyperactive mentalis. And class 2 recent malocclusion is also exhibits class 2 molar relationship. But the difference is that in class 1 infection, there was proclamation of the upper anterior, but in class 2 division 2, there will be major inflammation of the central incisor or central and lateral incisor. As a result of which, there will be severe deep bite or a closed bite will be present, and upper arch will be having a square shape. And because of this retroclined anterior, they will be continuously traumatizing on the visual detail of the lower anterior. As result of it, there will be severe finger deception, which will be seen in the lower anterior region. Another subclassification of patient 2 is class 2 subdivision. That is, where there will be class 1 on one side and class 2 on the other side. So one side there will be class 2 and on the other side there will be class 2. So this could be stated as class 2 subdivision. Now moving on to class 3 malocclusion. Here the molar nation is stated that the mesobuccal cusp of upper first terminal molar will occlude with the interdental media or interdental fronta in between the lower first and second molar. And the canine dimension, the canine, the cusp of the canine will be occluding in the interdental area between the lower first and second premolar. And there will also be duration in the line of occlusion. Other features of class 3 malocclusion include there will be reverse overtake of anterior crossbite, which can be seen in this figure, increased chance of natural anterior crowding, and posterior crossbite. It can be subdivided or it is further classified into two class 3 and zero class 3. The two class 3 is a condition in which there will be underlying skeletal discrepancy, that is, there will be evident skeletal discrepancy, which can be either a retrognatic maxilla or a deficient maxilla, prognatic mandible, or a combination of both. In this, there is a major having class 3 molar instances, both in centric occlusion, that is, when the teeth are in occlusion, and also when the teeth are in rest position. So that is acute class 3, which is due to an underlying skeletal discrepancy. Pseudo class 3 is a condition in which patient will be having a class 1 relationship when the teeth are not in occlusion, whereas when the teeth are closed, because of some underlying occlusal prematurity, the teeth will be sliding into this occlusal prematurity and will be coming into class 3 relationship when the teeth are in closed position. This type of malocclusion is mainly produced by forward movement of mandible during jaw closure. Thus, it is called as transfer or habitual class 3 malocclusion, which could be due to underlying occlusion prematurity as a result of the mandible slides forward into pseudoclasticity. So, at rest position, we'll be having a normal molar relationship. On centric occlusion, they'll be sliding over this prematurity, premature occlusal contact, and give us the class 3 relationship. Also, another classification of class 3 is class 3 can also have a subdivision, like wherein there will be class 1 molar relationship on one side and class 3 relationship on the other side. So what are the merits of Andy's classification of malocclusion? As we know, it's one of the most traditional and oldest systems that is still used by the clinicians worldwide, and most practical and easy to comprehend method of classification. It's most popular, easy to communicate, and widely used for teaching purposes. What are the major delimitations? Andy's classification is mainly a two-dimensional classification of malocclusion. It's not a he has not considered a three-dimensional problem, where a malocclusion is actually a three-dimensional problem. And this classified it based on only certain 2D relations. So some of the main demerits are to disregard the relations of teeth to the trees. Malocclusion is a 3D problem, but I'm considered only the fragile dimension. The position of maxillary molar is not stable, as stated by Andy, because the molar can have increased chance of migration, or it could be periodically. Migration is high stage for active molar, so that's also dangerous. Classification is not applicable in the first molar condition. It's not applicable in deciduous condition. When there is migration of first molar, the classification is not feasible. Etiologic modification is not known. Skeletal problems are not given consideration. Differentiation between dental alveolar and skeletal malocclusion is not possible, and the classification considers only static occlusion. There are certain modifications of Andy's classification. One is Lisch's modification, another is Dewey's modification. In research modification, what Nisha did was he introduced certain nomenclature. He altered the name or he modified the name. Suppose the angle. As class 1, he gave some certain nomenclature to it like nucleocclusion, dislocation, mesocclusion. And he also added the word suffix to describe the magnitude of individual things. These indicate a direction of deviation from normal distance. That is, like mesoversion, the mesory inclined, distroversion, lymphoversion, medioversion, that's the proclamation, infraversion, that's infrafluency, supraversion, suprarespiratory, activersion, passiversion, and transversion. UA modification. UA modified using angles class 1 and class 3 into further types. Class 1 divided into first 5 different types and class 2 into 3 different types. Class 1, type 1 into crowding of the maxillary anterior. Type 2 profound of maxillary anterior. Type 3, lymphoversion or lympholympine maxillary incisions resulting in anterior crossbite. Type 4, incisors in canines and nominal but molars and premolars are in buccal motion, resulting in posterior crossbite. Type 5, mesioversion of molars, that is wherein the molars are moved into due to premature loss of hydroxyl state, causing the maxillary performance molar to migrate locally. Class 3, type 1, well-aligned teeth and dental arch, and in express relationship express. Type 2, solid mandibular incisors and normally placed lower incisors behind upper incisors. Type 3, crowded maxillary incisors and undeveloped maxilla resulting in anterior crossing. Thank you.